Good morning. Welcome to AETCM. Today I'll be presenting a case of a 59-year-old male, a known case of CAD and type 2 diabetes mellitus, who came to the emergency room with complaints of fever. The fever spikes were high grade in nature, intermittent, associated with chills. Patient also had complaints of cough with mucopurulent expectoration, which is progressively worsening over the past 10 days. Patient also had complaints of dyspnea on exertion, grade 3, over the past 10 days. Over the past 3 days, patient developed a right-sided chest pain, which worsened on deep inspiration and during coughing. Patient came to the emergency room due to acute worsening of the above-mentioned symptoms.
Okay.
Patient has no known history of COVID, TB, pneumonia, or any other respiratory ailments. Patient was a smoker 10 years back.
Okay.
Other than that, patient had no significant travel history or occupational history. Vitally, patient was tachycardic with a heart rate of 111 per minute.
Okay.
Patient was febrile with a temperature of 101 degree Fahrenheit, BP of 100 by 60 millimeters mercury, and a saturation of 88% on room air.
Okay. Saturation was on the lower side.
Yes,
with
sir.
the tachycardia was also there.
Yes, sir.
And he was febrile also.
Yes, sir.
So from here itself, what did you do for this patient?
Sir, also on auscultation, there was decreased air entry on the right infraaxillary and infrascapular region. We started the patient on oxygen via nasal prongs, and ABG confirmed the same. Room air ABG showed a type 1 respiratory failure.
Okay. So what are the things that you, from the here itself, you can suspect this might be some conditions, no? What are the things that you're gonna suspect here?
Sir, given the patient's febrile status with the symptoms, it suggested an acute infection of the lungs, could be lower respiratory tract infection, the pneumonia, but given the auscultatory findings, it could be associated with an effusion, a pneumonia with an effusion associated with it.
Okay. How about is there a chance of any other no other comorbidities, right?
Just diabetes, sir.
Diabetes. Okay. Okay.
Patient had a history of CAD, but on arrival the ECG just showed sinus tachycardia. Echo showed good
LV. Okay. You did the echo.
Yes, sir.
So during echo itself, you can look for how's the chest also, no?
Yes, sir.
Yeah.
An USG test was also done. Initially, the X-ray was done, which showed a right lower zone patch with right costophrenic angle blunting.
Okay.
USG test done showed 250 to 300 ml fluid with septations with underlying lung collapse.
Okay. Septation was also there.
Yes, sir.
Okay.
The point of care showed a total count of 15,000 with neutrophilic predominance and a CRP of 180.
Okay.
So patient, a USG guided thoracentesis was done for diagnostic purposes.
Okay, when will you do thoracentesis? For each and every patient, will you do thoracentesis, or is there a criteria for the same?
Sir, normally either based on the quantity of the fluid present, for mild effusions, it can be monitored on observation. Less than 200, usually we monitor on observation. But over here, the USG suggested fluid of more than 300, and given its potential infective nature, we had to get a diagnostic tapping done to rule out any exudative effusion. So other than that, so we attempted a tapping, out of which 150 ml of straw-colored fluid was aspirated. The fluid study was as follows: pH of 7.05, protein of 4.5, LDH of 1500, glucose of 35, and total count of 4000, which was 90% neutrophilic.
Okay. So what is this? Is this an exudative or a transudative?
So based on our Leitz criteria, this falls under an exudative picture.
Okay. Can you explain the Leitz criteria?
Yes. So in the Leitz criteria, the fluid protein, protein to a body protein must be more than 50%.
Okay.
The normal body protein would be around 6, and given the fluid protein is 4.5, it is above 50%. The high LDH value of 1500, which is more than 2/3 of the Okay. And also low glucose level of 35 suggestive of an infection. Low pH 7.05 and total counts of 4,000, it's 90% neutrophilic.
Okay. So that's it regarding Leitch criteria and about pH. So if the pH is on the lower side and glucose is on the lower side, these things are suggestive of
infective
etiology. Okay.
And given the X-ray showing a lower zone patch along with an effusion, could be could suggest of a parapneumonic effusion. The patient was initiated on antibiotics, and since the USG showed loculations along with the low pH and high LDH, this was considered under a complicated effusion under the parapneumonic, under the Porcel and Leitch classification.
Okay. So, can you explain regarding types of parapneumonic effusion?
Yes, sir. So, there are 7 classes in the Porcel and Leitch classification. Class 1 to class 3 would fall under normal pleural effusion, where class 1 is not significant, class 2 is typical, class 3 is borderline pleural effusion. Over here, the pH will be above 7.2. And the glucose will also be above 40. The glucose will be above 40 with cultures negative. Class 4 and class 5 comes under your complicated effusions. Class 4 is simple complicated and class 5 is complex complicated effusion. In both class 4 and class 5, the pH will be less than 7.2 with glucose less than 40. The cultures can be positive or negative. But simple has no loculations. Complex will have multi-loculation. Class 6 and class 7 are empyemas. So empyemas, the fluid is completely full of pus. Class 6 has just one loculation of free pus. Class 7 complex empyema will have multiple loculations with pus.
Okay.
So this our case fell under class 5, complex complicated effusion. So USG guided pigtail insertion was
done. Okay. So for the same, there are like parapneumonic effusion will be there, loculated will be there, empyema will be there. So how can you differentiate these things on X-ray and USG basis?
Sir, in X-ray, the classical signs would be the blunting of the costophrenic angle, and you'll get a meniscus sign in uncomplicated effusions. You get a
meniscal
sign. In terms of USG, you get a honeycombing sign in cases of septations, where you'll see the fibrinous strands in between. So a honeycombing sign and a plankton sign will also be noticed.
Plankton sign.
Other than that, a jellyfish sign where the underlying collapsed lung segment will appear as a jellyfish.
Okay.
And a spine sign can also be visualized, where normally the spine will not be visualized in a USG, but due to the presence of fluid, the spine can be visualized.
Okay.
So these are the USG finding. A USG guided pigtail insertion was planned and done, and the exudative fluid was drained. Due to the presence of septations, 2 doses of intrapleural streptokinase is also administered to break the septations.
Okay.
And once X-ray showed resolution and the drain was reduced, the pigtail was removed.
So, how many days for this first to be done? After how many days the resolution occurred for this guy?
So it took 4 days, where 2 doses of streptokinase also administered in between.
Okay.
Because on day 2 the drain had come down, but the X-ray did not show complete resolution. So streptokinase was administered, and then the loculations was broken. And once the complete fluid is drained, X-ray showed resolution. On day 4, the pigtail was removed.
Okay. So any further things that you want to add here? No, okay.
Yes.
So we'll talk about parapneumonic effusion here. So this is parapneumonic effusion, no?
Yes, sir.
Can you explain about the pathophysiology regarding pneumonic effusion?
Sir, in cases of pneumonia, there can be that it will lead to inflammation of the alveoli and the vessel surrounding, which leads to vasodilation in the lung segment, leading to a loss of fluid from the vessels into the third space, which leads to effusion.
Effusion will be there, and later on this will go into effusion, fibrosis.
Yes, fibrosis, and finally into
and later on you can either have a disease progression or resolution can
So the empyema can become can get into the can enter the lung causing a bronchopleural fistula, or can come outside the thorax leading to an empyema thoracentesis.
Okay. So any indication for bronchoscopy in these conditions?
Sir, if there is any suggestion of endobronchial mass, or if there is a suggestion in a further evaluation including a CT, and if we notice a mass obstructing the particular segment, a bronchoscopy can be warranted.
Okay. Which are the conditions that we will go for CT rather than stay with our basic X-ray and USG in this condition? When you guys will do for a CT? Any specific conditions?
Sir, normally, usually in complicated effusions, a CT can be warranted.
Okay.
And if there is also in case of certain pleural thickening, in case of empyema and pleural thickening where USG will not be able to quantify, or we might need a CT.
We will do a CT. Okay. So regarding treatment, what are the things that you have to do?
So treat the underlying pneumonia. So start the patient on broad coverage antibiotics, and once if any cultures turn positive, change accordingly. So treat the underlying pneumonia, and for the first 3 classes, if the effusion is less than 200 ml, you can observe over repeated serial X-ray monitoring. You can observe, and then the effusions tend to resolve. But if on diagnostic tapping you get a infective etiology with a high LDH and low glucose level, it warrants immediate drainage, which can be done either through an ICD or a pigtail. But in resistant cases, or if there is severe septations and loculations, might also warrant VATS.
VATS. Okay. So you had we'll have some suspicion during this condition. No? What are the DDs for, like, if a patient is coming with a parapneumonic effusion as such? What will be the DDs for effusion?
Sir, even the loculations can also be a tuberculous effusion. Tuberculous effusion has to be ruled out.
Okay.
And also with an ADA was not checked, but in case ADA was checked, and if it's a high ADA, also malignancy has to be ruled out. Given the history of smoking and the age, a malignancy should also
be ruled out. Any other, when other things are very less likely, any other diagnosis? Sometimes we can see pulmonary embolism with infraction also can be kind of similar pattern in X-rays we can see. Okay, so how about the prognosis? How will be the prognosis?
Sir, recurrent since it's an isolated effusion with underlying pneumonia, once the antibiotics are administered and the fluid was drained, patient improved symptomatically, and was the oxygen requirement was brought down, and the patient was symptomatically better after 7 days of antibiotic administration. Sir.
Okay. And like it is usually like that, or in
certain cases, in recurrent effusions, or in case of in complex empyemas, the prognosis will be slightly bad given the need for given the needs for VATS decortication and other invasive procedures. And the chances of the empyema causing further complications like a bronchopleural fistula or draining out through the chest wall. So those cases, the complications might lead to a bad prognosis. But in our case, the patient recovered.
So there is chance that patient can have recurrence and also complications. Okay. Anything else you wanna say? Okay.